The Ontario government has announced that its goal is to make this province the healthiest place in North America to grow up and grow old by making sure that families get the best health care where and when they need it. In January, the government set out its action plan for healthcare that will shift spending to where it gets the highest value for investment. The plan will transform healthcare to ensure that it is centered on the patient and will invest health dollars where patients need it the most. It will also limit year-over-year expenditure growth. How? The province is reforming the way it funds healthcare services to drive quality, efficiency, and effectiveness in the system. We'll get there by moving away from the current global provider-focused funding model, in which every hospital receives the same percentage increase each year, towards a patient-based funding model, in which funding follows patients as they access the services they need both in hospital and in their community. Ontario can be proud of the many efficiencies it has already realized in our healthcare system. We need to keep that momentum going, and that's why we need to act now to ensure the system we rely on continues to become even more efficient and sustainable for generations to come. To achieve sustainability, the healthcare system must undergo transformative change. What is global funding? It is the funding system for hospitals that Ontario has used for decades. Essentially, hospitals have been getting annual, across-the-board, small percentage increases each year. Let me stop there for a moment and talk about some of the pitfalls of global funding. Global funding does provide administrators with some degree of certainty about their budgets, but there are major disadvantages too. 1. Evidence shows that there are wide variations across regions and across institutions in quality, cost-effectiveness, and type of care delivered. 2. Historically, the inequities between providers are perpetuated each year, and funding does not reflect new standards of care or the most efficient and effective practices. 3. Global funding means that healthcare providers have to deal with shifts in volume and intensity of cases, but within a static funding base. 4. Global funding creates a tendency to manage from the margins in without a clear understanding of cost structures. That makes it difficult to find efficiencies in a time of restraint. 5. Related to that issue, during times of restraint, hospitals typically restrict admissions so the wait times increase. That can't continue without abandoning the quality agenda. Those are just some of the reasons why most developed countries in the world have shifted away from global funding to an activity-based approach that focuses on patients. Here in Ontario, we call that approach patient-based funding. It will be phased in over the next 3 years so that healthcare providers can anticipate changes and plan for impacts. Patient-based funding will see healthcare providers compensated based on how many patients they look after, the services they deliver, the evidence-based quality of those services, and the specific needs of the population they serve. Patient-based funding has 2 components. 1. Health-based allocation model. The Health-Based Allocation Model, or HBAM for short, will be used to determine the appropriate amount of funding for each hospital, taking into account the characteristics of the patients being served. Demographic, clinical, and financial data will be used to estimate expected healthcare expenses at the hospital level. 2. Quality-based procedures. The second component is known as Quality-Based Procedures, or QBP. Quality-based procedures are groups of services for specific types of patients. QBP will help to standardize care and, along with that, minimize practice variation and allow patients, wherever they may be, to receive the best practice care at the right time and at the right place. In Year 1, the first set of patient groups will be implemented. They are total hip replacement, total knee replacement, chronic kidney disease, cataract surgery. Under the quality-based procedures approach, healthcare providers will be reimbursed for the number and type of patients they treat and the quality of care delivered. Funding will be allocated to specific groups of services based on a price times volume basis. This is meant to encourage providers to use evidence in their care delivery models. How were the patient groups selected? We considered the evidence and looked at many clinical patient groupings. Specifically for each of these groups, we examined the cost impact, Does the clinical group contribute to a significant proportion of total healthcare costs? Will this group give us the best bang for our efficiency buck? And is there significant variation across providers in unit costs, volumes, and efficiency? Feasibility and reporting infrastructure. Is this clinical group ready for change? That is, are there clinical leaders associated with the clinical group that are able to champion this change? And is there data and reporting infrastructure to support the change? Availability of evidence. Will we be able to measure and track the change for this clinical group? That is, does the clinical group have established standards or pathways of care? Is costing and utilization information available to let us know reference costs and pricing? And finally, practice variation. Does this clinical group vary in clinical outcomes across providers, regions, and populations that should be addressed? From the evidence, we have determined that hip and knee replacements, cataract surgery, and chronic kidney disease are excellent quality-based procedures to launch in year one of funding reform and are most likely to have the highest impact. Other groups will be phased in during years 2 and 3. Hospitals are more likely to invest in patient safety and improve quality of care if we target clinical areas that link evidence to patient care and improve quality. Also, moving toward evidence-informed pricing would support a shift from cost containment to quality improvement. And most importantly, it means patients will receive the best practice care at the right time and in the right place. QBP is a shift away from paying for select services towards paying for the care of the patient's entire journey across all providers in the hospital visit. This includes pre- and post-operative activities where that is appropriate and feasible. So, in a very real way, funding follows the patient. Let's say a patient needs a total hip replacement and requires both surgery and rehabilitation. QBP sets out how much money the hospital and the rehab facility will receive for their contribution to that patient's entire care journey. What will health system funding reform look like in Ontario? Over the next 3 years, we will gradually move from global funding that is provider-focused toward patient-based funding. Global funding will not go away altogether. It will still be used to determine funding for activities that can't be modeled or that are otherwise unique, like outpatient service costs, small hospitals, and forensic health inpatient facilities, for example. Of course, we will be making special provisions for academic hospitals and large community hospitals with a teaching component to recognize the increased costs of conducting procedures in a teaching setting. So, for the first time and on a large scale, Ontario will be reimbursing hospitals based on what they actually do, rather than simply providing them with across-the-board increases, regardless of their activities. As the new model is phased in, health service providers will be required to make base budget adjustments within the fiscal year to ensure a balanced budget. In April 2012, 54% of the hospital funding will still use the global funding model to reimburse healthcare providers for services. 40% of hospital funding will begin to use the HBAM model, and 6% of hospital funding will use the quality-based procedures to provide evidence-informed allocations to healthcare providers on a rate times volume basis for total hip or knee replacements, chronic kidney disease services like dialysis and cataract surgery. In April 2013, we expect to introduce additional quality-based procedures, which will reduce global funding to 45% of hospital funding, down from 54%. And by April 2014, there will be approximately 30 targeted quality-based procedures participating in the new model, accounting for 30% of hospital funding. Year over year, global funding will be reduced in proportion as QBP increases. By 2014, patient-based funding will comprise 70% of a hospital's funding. There are currently 152 public hospital corporations. Of these, 55 hospitals are defined as small and are excluded from the health funding reform. Of the 91 hospitals included in funding reform, we expect that in 2012-2013, 60% or 54 hospitals will see gains, while the balance will experience some level of funding decrease. And About 90% of hospitals, or a total of 79 hospitals participating in the reform, will see no more than a 1% swing in funding, up or down. Furthermore, of the remaining 10% of hospitals, 12 hospitals in total, increases will be no greater than 3% and decreases no greater than 2%. Funding reform, also known as patient-based funding, is not new. In fact, Ontario is one of the last jurisdictions to move down this path. However, we can benefit from the experience of others and see how patient-based funding has breathed new life into hospitals around the world. The benefits of patient-based funding are undeniable and lead to decreased wait times and improved access to care, reduced unit costs per admission, reduced variations in both costs and clinical practice, and improved quality overall. And that's exciting. The Ministry wants to minimize any disruption to services and impact on health human resources. We will be providing transition strategies, education, toolkits, and other support to assist health service providers throughout the change. There will no doubt be challenges as we move forward with this and other aspects of the healthcare system reform. But the path to quality and sustainability is clear, and a funding approach that follows the patient will be key to our success. Focusing on patient needs, on evidence-based practice, and on efficiency, value, and sustainability makes sense for us today and for future generations. Thank you.